Good evening everyone, how are you? Hope you are doing good. I am Dr. SULTHAN RASHID, consultant diabetologist at Ammaar, Chennai. Today I am going to talk about one of the important topics, that is diagnosing diabetes and the current screening protocol for prediabetes and diabetes. Let's go into the topic. Prediabetes is identified by the presence of impaired fasting glucose IFG, that is 100 to 125 mg per deciliter, impaired glucose tolerance, that is IGT, which is a plasma glucose value of 140 to 199 mg per deciliter 2 hours after ingesting 75 gram of glucose, or HbA1c value between 5.7% and 6.4%. So what is the diagnostic criteria for diabetes mellitus? It is based on either one or more of the following criteria. A fasting plasma glucose FPG of more than 126 mg per deciliter after at least 8 hours of fasting. A plasma glucose concentration of more than 200 mg per deciliter 2 hours after ingesting a 75 gram oral glucose load after an overnight fast of at least 8 hours. Patients with symptoms of hyperglycemia characterized by polyuria, polydipsia, polyphagia, and a random plasma glucose concentration of more than 200 mg per deciliter. And a patient having HbA1c of more than 6.5%. The diagnosis of diabetes requires at least 2 abnormal test results, either from the same sample or 2 abnormal results on the samples drawn on different days. Type 2 diabetes is characterized by progressive loss of beta cells insulin secretion along with variable changes in the sensitivity towards insulin. As per recommendation, all adults of 35 years with risk factors should be screened for diabetes. Then we talk about the type 1 diabetes. The patients have marked insulin deficiency, which results in hyperglycemia along with positive autoantibody tests to glutamic acid decarboxylase GAD65 and pancreatic isolated beta cells, tyrosine phosphatase IA2 and IA2B zinc transporter, that is ZNTH. The clinical presentation and the presence of immune markers help in differentiating the type of diabetes in children or adults, which further determines the course of the treatment. Young patients presenting with the symptoms of hyperglycemia must be evaluated to determine the type of diabetes. Then coming to the monogenic diabetes mellitus. Always consider evaluation for monogenic diabetes mellitus in any child or young adult with an atypical presentation, clinical course or response to therapy. Monogenic diabetes mellitus includes neonatal diabetes and non-autoimmune diabetes of multiple genetic causes, also known as MODY, maturity onset diabetes of the young. Most children with diabetes mellitus occurring under 6 months of the age have a monogenic cause, as autoimmune type of diabetes rarely occurs before 6 months of the age. So what are the glycemic treatment goals for persons with diabetes mellitus? First we'll talk about the outpatient glucose targets for non-pregnant adults. So we have to maintain HbA1c level of less than 6.5% is recommended if it can be achieved safely. To achieve this target of HbA1c level, fasting plasma glucose may need to be less than 110 mg per deciliter, and the 2-hour postprandial glucose may need to be less than 140 mg per deciliter. As per the recommendation, glucose target should be individualized with consideration for life expectancy, cardiovascular disease risk factors, disease duration, presence or absence of micro and macrovascular complications, comorbid conditions, and risk for hyperglycemia, as well as persons' cognitive and psychological status. Less stringent glycemic goals about HbA1c of 7 to 8% should be targeted in persons with history of severe hypoglycemia, hypoglycemia unawareness, limited life expectancy, chronic kidney disease, extensive comorbid conditions, or long-standing diabetes mellitus in which the HbA1c goal has been difficult to attain despite intensive efforts, so long as the person remains free of hyperglycemia associated symptoms. So what are the inpatient glucose targets for non-pregnant adults? As per the recommendation, for most hospitalized persons with hyperglycemia in both the ICU and non-ICU settings, we should maintain a plasma glucose range of 140 to 180 mg per deciliter should be maintained, provided this target can be safely achieved without causing hypoglycemia. Thank you so much for your kind attention, and kindly share my lecture to your friends.